The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The broadcast is now starting. All attendees are in listen-only mode.
Alrighty, guys, let's go ahead and get started here. Good afternoon. Hello, hello. So my name is Megan Roden, and this morning, well, it's 11 o'clock here in Florida, I am going to be teaching our question clinic today. It's on physiological integrity, pharmacology, and parental therapies, reduction of risk control. So if you can hear me, if the audio is okay, if the sound is good for you, please just go ahead and put in the chat box that we are good to go, and then we will get started. Sound is good and clear. Okay, very good. I did have somebody put in the chat box already. How is NGN so far? I'm hearing good news about it, but I can't help to be nervous. Oh, I think everybody is nervous going into the NCLEX exam, but I have heard positive things as well about the NG from a few testers who have taken it. We should get a big lump sum of results back today as it is Monday. So hopefully we will have a little bit better information for you. But so far, I think overall testers have found that they have enjoyed taking the NGN version of the NCLEX exam. So without further ado, we will go ahead and get started. As you guys know, if you've been in Question Clinic before, we will be going through a series of questions today. We will give you about 2 minutes to be able to answer the questions. We'll come back together. We will discuss the rationales, and then we will continue that through the duration of today's presentation. All righty, so let's talk about some subcategories real quick before we actually deep dive into the questions. So physiological integrity is one of the NCLEX client needs categories. It has 4 subcategories. So basic care and comfort, physiological adaptation, pharmacological and parental therapies, and reduction of risk control. So last week, we did the first 2. This week we are doing the second half. So what does that mean? What are the topics that are under pharmacological and parenteral therapies? So that's things such as medications, expected actions, side effects, adverse reactions, contraindications, and interactions. We have medications that are administered, pharmacological pain management, parenteral and IV therapies, TPN, total parenteral nutrition, blood and blood products, central venous access devices, and dosage calculations. So this will consist of about 12 to 18% of the NCLEX questions. Next is reduction of risk control. This is changes in abnormalities or vital signs, therapeutic procedures, diagnostic tests, lab values, potential for alterations in body systems, potential for complications from or of things like tests, treatments, and procedures, and potentials and complications from or of health alterations, surgical procedures, and system-specific assessments. This will be about 9 to 15% of your NCLEX questions. So guys, as we go throughout today's session, do not forget your 6-step strategies for question success. Utilizing these strategies as you go throughout the questions is going to help you successfully get to the right answer. So if you have not already listened to this pre-recorded webinar on Learn Upon, I highly suggest you do so. First step in the 6-step strategy for question success is to determine the type of question. Is this a SATA question? Is this a prioritization question? Is this a delegation question? Step number 2, you're identifying the topic. You're saying, well, what is the topic of this question? What is the tester looking for me to answer? Step number 3, you're looking for those keywords or clues, key phrases that's going to help you ultimately answer the question. Step 4, you're applying your knowledge of the topic. You're saying, well, what do I know about this topic? Step 5, you're saying, you're looking at your answer choices, you're reviewing, and you're eliminating the incorrect answers. Step 5 is where in a SATA question, you turn each one of your answer choices into a true or false statement, and you give yourself a rationale for each one as to whether it's true or false. And step 6, you're going to reread the question with the answer you have selected to make sure it makes sense, to make sure that you are indeed answering the question that is being asked of you. And some types of NCLEX questions we're going to see. So SATA, prioritization, delegation, therapeutic, and then those decision tree questions, which are the apples and oranges, umbrella questions, fixed versus flexible. All right, so question number 1. The nurse is working in the emergency department. Which patient should the nurse see first? Is it going to be number 1, a 10-year-old with severe neck spasms who is taking haloperidol for Tourette syndrome? Is it number 2, a 75-year-old with irritability and agitation on alprazolam for 2 weeks? Is it number 3, a patient taking olanzapine who has sudden onset of high fever, diaphoresis, and change in mental status? Or is it number 4, a patient taking olanzapine who has a dry mouth, blurry vision, and constipation? All right, guys, so don't forget to use those 6 steps we just talked about. I am going to go ahead and give you 2 minutes on the timer. Once the 2 minutes are up, we'll come back. I will reveal the correct answer and then provide rationales as to why the other ones are incorrect. So 2 minutes on the clock, guys, and go. Alrighty, guys, so 2 minutes on the clock is up. I see a lot of you have put the similar answer in, so let's see if the overwhelming majority of you guys are correct. So if you chose number three, which the majority of you all did, you would indeed be correct. So the patient taking clonazepam who has sudden onset of high fever, diaphoresis, and change in mental status. That is going to be the person that you want to see first. This patient is exhibiting classic signs of neuroepileptic malignant syndrome. It's uncommon, but it is life-threatening adverse reaction to an antipsychotic medication. NMS is characterized by high fever, muscular rigidity, altered mental status, and autonomic dysfunction. Treatment would include supportive care, such as rehydration, cooling of that body temperature, and immediate discontinuation of the medication. Due to the life-threatening nature of NMS, this client needs to be seen first to assess for generalized muscle rigidity. Okay, so that's the reason why that one is correct. Let's talk about the rationale as to why the other ones are not. Why you would not see them first. Okay, so this is a prioritization question. So option number one, severe neck spasms in an individual taking haloperidol and other psychotropic meds, indicate a dystonic reaction. This client is in no immediate danger, but does need IV treatment with benzotropine, which is cogentin. As soon as possible, the client should be seen second. Okay, so if we were ordering these, this one would be your second one to see. Option number two, benzodiazepines can cause paradoxical worsening of agitation in elderly clients. This client needs a change in medication, but does not need to be seen on an immediate basis. And option number four, dry mouth, blurry vision, and constipation are common anticholinergic side effects of olanzapine and other psychotropic meds. These symptoms usually resolve after the client has taken the medication for a few weeks. Treatment is symptomatic, so things like increasing fluids, sugar-free chewing gum, high-fiber foods, avoid driving. So this client can be seen last out of the four that we have. So if you chose number three, the patient taking clonazepam who has sudden onset of high fever, diaphoresis, and change of mental status, that would indeed be the patient you are seeing first. Alrighty, very good. Let's go ahead and move on to the next question. Question number two. The nurse helps the physician perform a bedside thoracentesis. In which position does the nurse place the patient to facilitate needle insertion and to promote comfort? Is it number one, in the fetal position, lying on the unaffected side with knees drawn to the abdomen and hands clasped around them? Is it number two, lying on the affected side with the head of the bed elevated 30 to 45 degrees? Is it number three, prone with the head turned to the affected side and arms overhead supported by a pillow? Or four, upright leaning forward over the bedside table with arms supported on the pillows? So we're looking for a position of comfort during a bedside thoracentesis. So guys, 2 minutes on the clock here, then we'll come back and we will discuss the rationale. So 2 minutes, guys. Alrighty, guys. So coming back together to reveal the correct answer, I think that the overwhelming majority of you guys have answered number 4. So this would indeed be correct. So during a thoracentesis, a needle is inserted into the pleural space to remove fluid for diagnostic or therapeutic purposes. Before the procedure, the nurse places the client in an upright sitting position on the side of the bed, leaning forward over the bedside table with arms supported on pillows. This position ensures that the diaphragm is dependent, facilitates access to the pleural space through the intercostal spaces, and promotes client comfort. Option number 1 is not correct. This is indicative of a lumbar puncture. The fetal position is appropriate for a client having an LP, but not a thoracentesis. Number 2, if unable to sit, the client can be positioned lying on the unaffected, not the affected side, but that's only if they are unable to sit. Option number 3, a prone position is not used for this procedure. It's uncomfortable and it would make it more difficult for a client with dyspnea to breathe. Remember, the patients undergoing a thoracentesis have that space filled with fluid, and we are evacuating the fluid when we do the thoracentesis, so making it more difficult to breathe. So we wouldn't want them in that prone position. So if you chose number 4, you would indeed be correct. I have a question. Arlene says, I just want to ask what to instruct the patient to deep breathe in and hold, or just to keep normal breathing? Just to keep normal breathing is appropriate. Now the doctor may say, okay, on the count of 3, we're going to go ahead and insert the needle just to let the patient know and to be aware. Oftentimes patients will hold their breath just because that needle is being inserted. But while the thoracentesis is happening, while the fluid is being removed, it is perfectly acceptable for the patient to breathe normally. All righty, question number 3. So the home health hospice nurse visits a client who is newly prescribed extended release oxycodone, 40 milligrams orally, scheduled every 12 hours to treat severe chronic terminal cancer pain. Which information is most important to reinforce to the client's caregiver? Number 1, administer the medication around the clock, even if the client denies having pain. Number 2, avoid administering with immediate release opioids to prevent respiratory depression. Number 3, change the dose and frequency to 20 milligrams every 6 hours if breakthrough pain occurs. Or number 4, request a tapered dose from the healthcare provider if pain decreases to prevent tolerance. So which information is most important to reinforce to the client's caregiver? All right, so 2 minutes on the clock, guys, and then we will come back together and reveal the correct answers. So go ahead, 2 minutes, please. Alrighty, guys, so 2 minutes on the clock is over, and let's go ahead and reveal the correct answer. So if you chose the answer to be number one, you would indeed be correct. I had a few of you that said you changed your mind, you had put one option and changed it to another. So number one is correct, but let's talk about why. So number one, long-acting controlled release opioid drugs for chronic pain require regularly scheduled dosing to maintain a therapeutic drug level. Immediate release opioids may be required for breakthrough pain. Long-term opioid use leads to tolerance and physical dependence. Higher doses are eventually required for therapeutic effect. Option number two, this is incorrect. Immediate release opioids and non-opioids are co-administered with long-acting opioids for relief of breakthrough pain. Respiratory status should be monitored. However, clients who receive long-term therapy become opioid dependent and are less likely to experience adverse effects. Because the goal of hospice care is comfort, this client should be relieved of breakthrough pain regardless of respiratory status. Option number three would be incorrect. The dose and frequency cannot be changed without a prescription. Also, breakthrough pain is best treated with short-acting opioids. And number four, long-term opioid therapy leads to drug tolerance and physical dependence. Higher doses are eventually required for therapeutic effect. In the dying client, it is not appropriate to taper the dose. Rather, it should be titrated upward for effective pain relief. I do have a question in the chat box. Please explain the meaning of around the clock. So around the clock means as scheduled. So you don't want to stop the medication. You want to give it as scheduled, literally around the clock. So it's scheduled every 12 hours. You're going to want to give that every 12 hours around the clock. Around the clock is just a phrase that we use here in the United States, meaning you want to administer it when it's due. You want to keep going. You don't want to break that cycle. Okay. All righty. The medication is given on regular schedule RTC. I'm not sure. Oh, round the clock. Yes. Yep. It's given on a regular schedule. Yes. All right. Very good. That was why I didn't choose it, because I thought it meant out of schedule. Oh, no, it means around the clock means keep going, keep on the schedule, keep it every 12 hours for that treatment of severe terminal cancer pain, right? Because this patient is actively dying. They are home with hospice. So we want to, the goal of hospice, like I said, is for comfort measures for a patient with chronic terminal cancer pain. So we want to keep that medication around the clock. We want to keep it in their system with that chronic terminal cancer pain. All righty, great discussion. Let's move to question number 4. Oh, hold on. Please, did you say give immediate release opioid or non-opioid? The question here is extended release oxycodone 40 milligrams orally is scheduled every 12 hours. So we would want to administer the medication around the clock. Okay. All right, moving right along. Question number 4, guys. An experienced nurse precepts a graduate student in the intensive care unit while caring for a client with a right subclavian triple lumen central venous catheter, also known as a CVC. Which statement by the graduate nurse indicates understanding of the CVC? 1. All 3 lumens come together, so all drugs infused through the CVC must be compatible. 2. It is used to provide enteral nutrition to the client who cannot eat. 3. Sterile gloves must be worn when administering drugs through the CVC. Or number 4, the lumen hub should be cleaned thoroughly with antiseptic prior to drug administration. So I'm going to give you guys 2 minutes on the clock, and then we will come back and discuss the answers. So 2 minutes on the clock, guys. Alrighty, everyone, let's come back together. That's 2 minutes on the clock here. And if you chose answer number 4, you would indeed be correct. So the nurse should always handle the lumen ports and hubs aseptically with facilitated approved antiseptics to prevent catheter-associated infections. Let's talk about the others and why they are incorrect for this question. So option 1, CVCs may have multiple lumens. These are used to administer incompatible drugs simultaneously. They're used for blood draws and for hemodynamic monitoring. Option number 2 is incorrect. Enteral nutrition is given only through the GI tract, orally, or through a feeding tube. Parenteral nutrition is administered through the IV route via a central vein. Option number 3 is incorrect. Proper hand hygiene should be performed when caring for a CVC to prevent infection, and non-sterile gloves should be worn to protect the nurse from blood or bodily fluids at the port site, as one or more lumens are often used to draw blood. So the correct answer here is option number 4. The lumen hub should be cleaned thoroughly with antiseptic prior to drug administration. Alrighty, let's move to question number 5. A hospitalized client is scheduled for a percutaneous kidney biopsy at 10 a.m. At 8 a.m., the nurse reviews the client's vital signs and the most current serum laboratory results. Which finding is most important to report to the healthcare provider? Is it going to be number 1, blood pressure of 180 over 100, creatinine of 2, hemoglobin of 9.8, or a platelet count of 120,000? So 2 minutes on the clock and go. Alrighty, guys. So that's been 2 minutes on the clock. Let's come back together and I'm going to reveal the correct answer. So if you chose number one, you would indeed be correct. And here is why. The kidney is a highly vascular organ, and the risk of bleeding is a major complication after a percutaneous biopsy. Therefore, uncontrolled hypertension is a contraindication for a kidney biopsy, as increased renal arterial pressure places the client at risk for post-procedural bleeding. Blood pressures must be lowered and well controlled. So this would be a goal blood pressure of 140 over 90 or less. Using antihypertensive medications before performing a kidney biopsy. The client should have normal coag studies, an adequate platelet count, and well-controlled blood pressure prior to the procedure to reduce bleeding risks. So that is why number one is correct. Let me give you the rationales for the other three. So option two, an elevated serum creatinine level can be expected in a client with possible renal disease. So again, we're going back to that, is it expected or unexpected? Normal creatinine level is 0.6 to 1.3, so an elevated creatinine is expected. Number three, a decreased hemoglobin level can also be expected in a client with probable renal disease due to decreased erythropoietin production. The nurse should continue to monitor the client's hemoglobin post-procedure, as it can decrease further within 6 hours if bleeding occurs. And option four, the only neurosurgery and ocular surgery require a platelet count greater than 100,000. Most other surgeries can be performed when the platelet count is greater than 50,000. Although the platelet count is low, normal is 150 to 400, it is not the most important finding to report to the physician. Please confirm we're on question five. Yes, we're on question five. Dina, we are moving on to question six now. All right, so that is the answer to number five, is number one, controlling the blood pressure. Blood pressure of 180 over 100 puts that patient at risk for increased bleeding. So we've got to control the blood pressure. Optimally, we're looking for somewhere 140 over 90 or less. All right, guys, so let's start with our case studies. So as you guys know, we've already started NGN, so I'm not going to read this to you, but I do want you guys to understand that NGN is focusing on that interaction between the nurse and the client, our client's needs, and expected outcomes. So again, just a quick review of the nursing process with clinical judgment. As you guys know, the nursing process, the first step is assessment. That has not changed. It's always been an assessment. It always will be an assessment. So your first part of the clinical judgment is to also recognize those clues. And we're saying to ourselves, what matters most with our patient? What is happening? The next step in the nursing process is to diagnose. This is steps 2 and 3 of the clinical judgment model. Here we are analyzing clues. We're saying, what does it mean? And prioritizing hypotheses, saying, where do I start? The next step of the nursing process is to make a plan. This is where we are implementing solutions or generating solutions. Step number 4 of the clinical judgment model. The next step in the nursing process is to implement. This is step 5 for the clinical judgment model, and here we are taking action. We are saying to ourselves, what will I do? And the last step in the nursing process is to evaluate. So this is also the last step of the clinical judgment model. This is where we are saying, did it help? Is what I'm doing for my patient making a difference? All right, so let's start with our first case study question here. All right, so here's our scenario. The nurse is caring for a client diagnosed with Crohn's disease, scheduled for surgery for small bowel resection, and possibly to create a temporary ileostomy the next day. IM is our patient or our client, the 35-year-old female. She is 5'6" tall and weighs 120 pounds. She presents with complaints of progressively worsening frequent diarrhea, up to 8 stools a day by admission, with severe stomach cramps for the last 8 weeks. She rates her pain a 7 out of 10 when cramping, but states after passing stool it does lessen or resolve until the next bout. The pain is localized to the lower right quadrant, sometimes toward the umbilicus. She reports weight loss of 10 pounds in the last 2 months without intention. However, she has had decreased appetite because of the diarrhea and pain. She complains of feeling tired all the time and sometimes feels dizzy when getting up from lying or sitting. She just wants to feel better and the diarrhea and pain to stop. All right, so it's a pretty long scenario that they gave us here, but let's look at the vital signs. So she comes in with a temperature of 100.8 degrees Fahrenheit or 38.2 Celsius. Heart rate is 88. Respirations are 20. Blood pressure is 120/76. O2 is 99% on room air. So let's go ahead and click on the tab that says laboratory results to see if we have anything here for us. So we have laboratory results that are pending. So we did a CBC, a CMP, a CRP, ESRs, LFTs, occult stools, and an OMP. So those are all still pending. Let's click on medications. So we have budesonide, 6 milligrams by mouth daily in the morning. We have Humira, which is 40 milligrams, subcutaneous injection once every 14 days, and Imodium, 2 milligrams by mouth as needed up to 4 times daily. So as Crohn's and these drug classes are common NCLEX question topics. So make sure, guys, with these medications, you understand the purpose, the actions, the primary side effects, and adverse effects of nursing considerations. So let's go ahead and click on physician orders to look at the next slide. So the physician has ordered a CT of the abdomen with oral barium contrast, a clear liquid diet, NPO after midnight, to initiate a peripheral IV, Tylenol 500 milligrams, 2 tabs every 6 hours ATC, fentanyl 20 milligrams every 6 hours, and may take pain meds after midnight with a small sip of water. Okay, so these are the physician's orders. Please do note, guys, sorry, I had to take a sip of water. Fentanyl is an anticholinergic / antispasmodic drug and can be effective in reducing the cramping pain for patients with Crohn's. Opioid medications are avoided, as recent studies have shown that opioid use is a strong predictor of more severe disease and premature death in patients with Crohn's, while those who do not use opioids for pain have less severe disease and lower mortality. So something to keep in mind with this medication and with Crohn's disease in general. All right, so here's going to be our question. This is the first question in the case study, question number 6 in this presentation. So it says, click to highlight which findings require immediate follow-up by the nurse. So I'm going to give you guys 2 minutes on the clock. Please go ahead and click, or not click, sorry, you guys don't have that ability. Just put in the chat box the words or phrases that would require immediate follow-up. All righty. Here we go. So 2 minutes on the clock. Just go ahead and put in the words or phrases that you feel require immediate follow-up by the nurse. All righty, guys. So that's 2 minutes on the clock. I see lots of good information here in the chat box. I do appreciate when you guys put it all together in one lump answer for me there. So let's go ahead and see if you guys got the correct ones right. So what we would want to follow up immediately would be for progressively worsening frequent diarrhea, severe stomach cramps, pain 7 out of 10, but states after passing stool it does lessen or resolve until the next bout. Next is pain localized to the lower right quadrant. Weight loss of 10 pounds. That's pretty significant. Decreased appetite because of the diarrhea and pain. Tired all the time and sometimes feeling dizzy. And a temperature of 100.8. So those would be the ones those would be the things we'd want to follow up on immediately. All right, so question number 7. So it says here to click to identify the appropriate drug class for the medications listed. So for budesonide, what drug class is this, guys? Is this a bronchodilator, a corticosteroid, an anticholinergic, or a biologic? So I'll give you guys about 30 seconds on the clock here, guys. What is budesonide? What do we think budesonide is? All right, I see lots of people putting in the chat here. So it is indeed a corticosteroid. Budesonide is also called Enterocort, Uceris, or Pulmicort. Those are some of the common brand names, but it is a steroid and it can treat Crohn's disease and ulcerative colitis in its oral form. And then when inhaled, it can be used for asthma. So it is indeed a corticosteroid. All right, what about this next one? Adalimumab. What do we think this one is? A biologic tumor necrosis factor blocker, a monoclonal antibody, an H2 inhibitor, or a proton pump inhibitor? What do we think this one is? All right, so this is actually a biologic tumor necrosis factor blocker. So the common name is Humira, which is what you might have known this as. Okay, so Humira is a common name. It is an immunosuppressive drug. It can treat arthritis, plaque psoriasis, Crohn's disease, and ulcerative colitis. So this is indeed a biologic tumor necrosis factor blocker. All righty, so let's do the next one. What is loperamide? Is this going to be a probiotic, a laxative, a fiber supplement, or anti-diarrheal? See lots of things coming through the chat box here. So yeah, that is going to be an anti-diarrheal. So common brand names are things like Ultra AD or Diamode. It can treat diarrhea. It can also decrease the amount of drainage in patients with ostomy. So this is indeed an anti-diarrheal. Question number 8. So it's going to say here, based on the results of the lab work now received. So we'll review that in just a moment. What medication does the nurse anticipate receiving priority orders for at this time? So let's click here to reveal the drop down. All right, so let's talk about the lab results that have come in. So we have a WBC count of 13.2. We have an ESR of 60. We have a K potassium of 3.2. We have a hemoglobin of 10.5. We have a CRP of 90, a CA of 8.2, an HCT, which is a hematocrit of 32, an NA of 132, and an albumin of 3. So based on these lab results that have since popped up for us, what do we feel is going to be the priority order at this time? So is it going to be to administer 1 unit of RBC stat? Is it going to be to initiate potassium protocol to 4.5? Is it going to be a hypertonic saline, 1 liter over 10 hours? Or is it going to be Zosym, 3.375 grams IV every 6 hours? So I'm going to give you guys about a minute or so on the clock. Please go ahead and put in what do you feel is going to be the priority order at this time? What is the priority order here, guys, based on these lab results? All right, so let's go ahead and talk about it. So if you chose Zosyn, 3.375 grams IV Q6 hours, you would indeed be correct. So while the hemoglobin, the sodium, the potassium, the calcium, they're all low, none of them are life-threatening at this time. However, the elevated WBCs in light of surgery tomorrow, remember, this patient is being prepped for surgery tomorrow, places her at a high risk for severe infection, including peritonitis from surgery. The other low lab values can be addressed after the initiation of the antibiotics. Okay. Lab results in NGN with reference values included. Are you asking me if you're going to have the normal lab values? You may have the normal lab values, as I have heard that that is supposed to be given to you on the NGN NCLEX exam. And that is what I have gathered and what I have heard as well. Alrighty, so click or check to specify which nursing interventions are appropriate or inappropriate considering the patient's scenario. All right, so the scenario on the left-hand side of the screen has remained the same from the previous screen. All righty, so interventions. I'm going to read each intervention, and I would like for you to put if it is appropriate or inappropriate. You can put A or I. That's perfectly fine. So, intervention, placing on an ECG monitoring. Is this considered appropriate or inappropriate? Give you about 30 seconds here, 15 seconds. All right, so that's going to be appropriate. And we'll talk about why in just a few moments. All right, what about monitoring orientation and LOC? Is this going to be appropriate or inappropriate? Good, this is going to be appropriate. All right, what about assessing falls risk and assist with ambulation or transfers? Is this appropriate or inappropriate? So this is also going to be an appropriate intervention. What about ensure all 4 side rails are up on the bed at all times? Is this an appropriate intervention or an inappropriate intervention? So this is going to be inappropriate. Remember, restraints can further dilute electrolytes. So we don't want to put our patients all 4 side rails up because that is considered a form of restraint. Okay. Monitoring vital signs every 2 hours. Is this appropriate or inappropriate? This is appropriate. And the last intervention, strict eyes, nose, and ensure 200 mLs of fluids per day, greater than 200 mLs of fluids per day. Sorry, that's less than. This is going to be inappropriate. So, or sorry, that was greater than. I'm losing my mind this morning. Sorry. High fluid intake can further dilute electrolytes. So let's talk about reviewing the signs and symptoms of low electrolytes and H&H. So the symptoms of low hemoglobin and hematocrit are things like fatigue, weakness, patient may be pale or yellowish, irregular heartbeats, okay? So that's the rationale as to why this patient should be on ECG monitoring, right? That low H&H, shortness of breath, dizziness or lightheadedness, chest pain, and hands and feet that are cold, okay? We have a low sodium here. So some symptoms of low sodium could be things like nausea, vomiting, headache, confusion, loss of energy, drowsiness and fatigue, restlessness, irritability, muscle weakness, spasms or cramps, seizures, and coma. This patient also has low potassium. So things of low potassium, weakness, fatigue, muscle cramps, muscle aches, stiffness, tingling, heart palpitations again. So it's important to place this patient on ECG monitoring to monitor their orientation in LOC and to assess their falls risk, right? All of these electrolyte levels are low and could have very severe symptoms associated. Changes in or low calcium, extreme fatigue, lightheadedness, dizziness, brain fog, confusion. Okay, so we don't want to keep all four side rails up. Number one, that is a form of a restraint here in the United States. So we cannot have all four bed rails up at the same time unless this patient is in restraints and we have doctor's order, and that's a whole other conversation for a whole other day, as the restraint protocols are very strict here in the US. So we do not have all four side rails up at the same time. Let's see. I also have a question. What is my next question? Monitoring vital signs 2 hours is quite a long time. Yeah, you should definitely be monitoring them. Well, monitoring vital signs every 2 hours. These vital signs right now are stable. There are definitely, it can get lower, but monitoring the vital signs as long as your patient is stable, her blood pressure and things seem to be okay. You'll definitely want to assess her falls risk and assist with ambulation and transfers, but otherwise indicated vital signs every 2 hours is actually more than normal Q4-hour vital sign routine check. What if the patient is sleeping concerning the bed rails? Nope, you cannot have all four bed rails up. That is a form of restraint. Even if they're sleeping, you cannot. Strict I's and O's and ensure greater than 200 mLs of fluids a day. So more fluids can dilute your electrolyte levels. So we wouldn't want to have this person drink a lot of fluids, because that's going to decrease these electrolytes even further until we can start replacing electrolytes. Can you have two side rails up? You can have two side rails up. Yep, the top two side rails is appropriate. All four are considered a restraint, so you cannot have all four up at the same time. The patient has been having diarrhea. Rehydration should be appropriate. Rehydration should be appropriate, but done most likely IV and done with very close monitoring to those electrolytes. So it's a fine balance here. For side rails, you need a doctor's order. Listen very carefully, guys. If you have all four side rails up, it is considered a restraint here in the United States in Central Florida. You have to have an order for all four side rails to be up. The patient would be in restraints or have an order for restraints. Do not put all four side rails up. If you were ever being audited or the hospital were being audited and auditors were walking around the hospital, they looked into one of your rooms, saw a patient with four side rails up, they would say, "Where's your order for restraints?" That is considered a restraint. So please do not put all four side rails up at the same time unless your patient is in restraints and you have an order. Okay, moving right along here, guys. Question number 10. Which of the following nursing diagnoses does the nurse add to IM's care plan? So let's read the case study. IM has had an uneventful night due to close monitoring and management by the nurse. The next morning, she goes to surgery and undergoes bowel resection with temporary ileostomy creation. The nurse continues to monitor the surgical site, provide pain management and antibiotics as ordered, along with other ordered Crohn's management medications. The nurse provides teaching on the ileostomy management and incision care. So again, our question, which of the following nursing diagnoses does the nurse add to IM's care plan? Is it number 1, the potential for bowel obstruction related to Crohn's? Number 2, the potential for electrolyte imbalance due to diarrhea? Number three, the potential for body image disturbance due to the new ileostomy. Or is it number four, the potential for weight loss due to altered nutrition from poor oral intake? So I'm going to give you all 2 minutes on the clock. Please go ahead and put your answer into the chat box. All right, about 20 seconds left on the clock, guys. Please put your answer into the chat box. All right, so if you guys chose number two, you would indeed be correct. The potential for body image disturbance due to that new ileostomy. So we would want to provide teaching, we want to provide education as we are talking to our patient about what this new ileostomy entails. Remember, this patient is a 35-year-old, so body image disturbance in this age and phase of life definitely could be something that she's going to be dealing with. Okay. All right. So that's all that we have for today. I hope that you guys learned a lot from today's question clinic. We went over some good things, had some good discussion. So thank you all for being involved and for participating. And I hope that you guys have a great rest of your day. Roger says, I thought physical problems are priority over psychological. Psychological. So the physical problems, I'm not sure I understand your question, Roger. But please feel free to email me at mroden@avanthealthcare.com. If you have any further questions, I'd be happy to take this offline. But the answer, sorry, you guys seem to have a lot of questions regarding this. The potential for body image disturbance due to the new ileostomy, that is going to be a diagnosis that the nurse would expect to be added to IM's care plan, okay? How can we access the recorded clinic content? So that should be uploaded this week, guys, into your Learn Upon account. So give them a little bit of time. I do believe that they're in the process of uploading, but it should be in your Learn Upon account. All right. Let's see here. What else do we have? I have some, there's no present physical problems according to the assessment. Yes, Joanna, that is correct. So thank you for helping answer Roger's question here when he says that physical should become before psychological. So Joanna makes a great point that there's no physical problem according to the assessment. So that's why that answer would indeed be correct, that we want to talk with our patient about body image disturbance. All right. When will we get any notifications? I don't know that you will get any notifications, Cynthia, about your webinars being uploaded. You'll just need to simply check your Learn Upon account. Okay. Emily, I'm not able to go back for questions 1 through 5. I would encourage you to attend another webinar for the first half of today's presentation. If you highlight a part of the answer, will you be correct, Karen? That is a good question. If you highlight the main part of the answer, if you highlight like of or the or and, that's not going to give you the credit, but you've got to highlight like the actual word or term or phrase that the test makers are looking for in order to be correct. So I'm just trying to go over everybody's questions. All right, guys. Are there no more content clinics? That is correct. There's no more content clinics. All of the contents will be uploaded into that Learn Upon account for each of you at any time, which will be great because you'll be able to listen to the content as well as study at the same time. So now they will coincide, as before it was you could be studying cardiology and we could be presenting on maternity. So now you'll have the option of having them coincide together with study, which I think is going to be really great for everyone moving forward. So it will only be question clinics. Yes, you guys are more than welcome to go. I'm just answering people's questions in the chat box. I'll be signing off here in just a moment as we are officially out of time. But is the Learn Upon the same as the Nurse Achieve? No, Monique, I would highly suggest that you get in contact with your instructor, as a Learn Upon and Nurse Achieve are two completely different platforms that we use here at Avant. All right, guys. For example, the question we did, if you highlight pain and omit that she gets relieved after passing stool, will you be correct? Yes, Karen, I do believe that would be considered still correct because the whole point is that she is in pain. Yes, I do believe that that would be correct. All right, guys, thank you so much for attending. I hope you guys have a great rest of your day. If you have questions, please feel free. Again, mroden@avanthealthcare.com is my email address. You're more than welcome to email me. If there are specific questions about your study, please contact your specific instructor. All right, guys, thank you so much. Have a great rest of your day. Bye-bye.